So, a few of my slides are redundant, and I'll go through, but try to make a few points that the Dr. Woyak and Wiesner didn't make in their presentation. We all know about BTK, and one of the things that hasn't been talked about with these two targets that we're focusing on, BTK and P110 delta, is how we sort of could infer perhaps that this was going to be a good target to drug. And with both the P110 delta and BTK, the mouse models told us this a long time ago, in that there was predominantly, with both BTK and P110 delta, there's predominantly a B cell defect. And probably what distinguishes the two, I think we're seeing clinically, in that you see the B cell defect with the BTK XID mouse, and the knockout it's more deep. With the P110 delta, you see the same thing, almost the same identical B cell phenotype, but you have colitis in that mouse model, and we'll be hearing about this more. And that's something, as we give P110 delta inhibitors longer, that's something that's been seen in a subset of patients, and telling us that the mouse models can really help us. Ibrutinib, we've heard, is a potent BTK inhibitor. It doesn't only inhibit BTK, but it inhibits this irreversibly. And for this reason, you can give the drug for a very, you can give the drug daily and inhibit the target using a probe assay that was designed by Joe Buggy at Pharmacyclics. This agent, I think another thing we can learn from the development of this is it was active in a spontaneous dog model, and this could be your dog at home, because they get lymphoma frequently. And as we move up to spontaneous tumors in bigger models, we can be more assured that therapeutics are going to work in the clinic. The preclinical work, has been published with this, and clearly this agent works through a lot of ways, inhibiting proliferation, perhaps a modest amount of apoptosis, and interfering with integrin adhesion and stimulation. The phase 1 study that supported the pivotal study that I'll discuss had a very strong signal beginning in the second dose level all the way up, with 11 of 16 patients with CLL responding. Several of the patients on this initial study are still on it. And it was here also that the initial medical, the CMO of the company and Pharmacyclics got a hint, as did we saw with itolizumab, that you see lymphocytosis early with this, and the phase 1 study told us that this was a drug-related phenomenon, because when you stopped the drug, the lymphocytosis went away, and you'd start it again, and it would come back. And so this ultimately led to the pivotal study that ultimately formed the basis for the accelerated approval of ibrutinib. And this study had multiple arms. It started with 2 relapse arms, one at giving 420 milligrams once a day, a second arm giving 840 milligrams once a day, and then a third arm looking at relapse and refractory patients who were high risk, and then finally a treatment naive arm over the age of 65, who otherwise met criteria for treatment. The 2 papers have been published. We'll go through the data. For the relapsed and refractory patients, this was a heavily pretreated group of patients. But as Jennifer and I have talked, the median number of therapies here is 4. The median number of therapies with itolizumab is 5. So it's hard to compare the two, and I think that's going to be an exciting question for us in the future. In some way, is to compare these two, because they're definitely different drugs. These patients were heavily pretreated. With only a small subset having received other investigational agents or alemtuzumab. The adverse events went as we would expect. It's being seen more commonly in patients who had had prior therapy. In general, this was very well tolerated in the untreated setting. And this sort of looks at the adverse events, and you'll notice there's very, very little green in here, or orange, but the most common toxicities you see both in the treatment naive and the previously treated are diarrhea, nausea, fatigue, and again, these are generally side effects that you see early on and that go away with time. You do see bruising with this drug, although it's generally of no clinical consequence. This looks at hematologic, and non-hematologic toxicity as well as infections. And again, as you see in the previously treated patients, these are more frequent, whereas the treatment naive, the therapy is better tolerated. And still, these toxicities are relatively low, looking when you're considering how long patients have been followed and how heavily pretreated they were. This looks at the response, as presented in the paper, and there'll be an update of this. And I would say the response with this drug is sort of like wine. With time, it gets better, and it's continuing to get better. And Susan O'Brien will be presenting a poster discussion, I'm not sure, at ASH, where the responses are updated. But you see in the treatment naive, the response was 71%, the refractory 75%, but another 13% in each group, had this, persistent lymphocytosis, and a number of patients had stable disease. And this most often was a patient that had a 1.8 centimeter node or 2 centimeter node as their only measurable disease with cytopenias that didn't get under 1.5 centimeter. There are very few patients that started with 12 centimeter nodes and were at 10 centimeter nodes at the end evaluation. This makes the point with these drugs that when you give them continuously, particularly ibrutinib, say you see lymphocytosis, which resolves with time in most patients, but not all. And this initially made everybody nervous, but with the occurrence of this, you saw a reduction in nodes, improvement in counts, and patients feeling better. And so, this certainly should not connotate a reason for stopping therapy. This sort of gives a sense, and I think this is helpful, that probably the patients that have the highest rise in count are those patients who start with a relatively low count. And the patients, but there are some patients that start high, that go high. You see there are 4 patients that were above 400,000. I think our record is 700,000. And I will admit there's a little nervousness, but to my knowledge in CLL, there's not been a single person that's had complications with the lymphocytosis. There have been a couple of cases of mantle cell lymphoma where there was associated hemorrhage, but that was in the setting of progression more than likely. So really, wherever the count goes, generally it's going to come down, and if patients are not symptomatic, we worry. Who's not going to worry? But we don't freeze. We don't do anything differently. We don't stop the drug. This just makes the point that Dr. Woyak made in her presentation that, and I think what this study has taught me the most is everything that I've learned before with chemoimmunotherapy. I just have to ask the question again, is it true with targeted therapy? Because I would have expected that the orange PR with lymphocytosis would be reversed with the patients who had a CR and PR in this study, and it was the exact opposite. And so these data are still. This is a landmark analysis, it's from a year, but the data are still immature. We'll need to see how they go with time. But again, this just makes the point with these agents that we have to re-ask, some of the same fundamental questions that we thought we'd answered with our current chemoimmunotherapy approaches. This drug is very good at increasing hematologic response, both with thrombocytopenia and anemia, as is made point in this slide. And interestingly, one of the things we would have expected with a BTK inhibitor is that we would see worsening hypogammaglobulinemia. And so if there's anybody in the audience that can explain this, please come talk to Adrian or myself or Dr. Johnson, because we'd love to go to the lab and try to figure this out or have somebody else figure it out. But what you see is in the relapse and refractory patients, most of them start low, or some of them are on immunoglobulin, and we excluded the patients that were on immunoglobulin. But you really see no change in the immunoglobulins with extended treatment out to a year. In the untreated patients, what happens is the IgG and IgM remain about the same, so they're not statistically different. But interestingly, the IgA goes up, and this is significant at all time points. And why this is happening, I don't know. But we know that IgA is important for protecting against mucosal infections. And it's interesting with time when you look at the frequency of infections with this agent, both groups, the untreated and the treated group, the frequency of infection during the first 6 months versus the next, after that, it significantly goes down. This looks at the progression-free survival for all patients, and the untreated patients continue to do well. One of the things that I'll call attention to is that there are several patients, I believe 7 now, that stop therapy, some as early as 6 months. And to my knowledge, none of them have progressed. There's only been one progression thus far in this study. The relapse and refractory, this is a 26-month progression, or 26-month estimated progression-free survival of 73.6. If we look this is looking at the relapse patients, because unfortunately there are only 2 17P patients in this group. Adrian's study will tell us how the 17P will do with this in de novo setting. But in the relapse setting, I think an important point, this represents the non-deletion 17P, non-11Q group. And you'll notice that if you don't have either of those, you do similarly to the treatment naive. There have been very few relapses in this, in this group. Whereas the 11Q and the 17P, you see a drop off. And Dr. Woyak alluded to, and I was surprised when we looked at our own data that the frequency of progression doesn't only occur because patients stop drug, but don't stop drug because their disease is progressing, but that group of patients also tends to have more toxicity, probably because they were more heavily pretreated. And again, as studies mature, and this study matures and others come forward with less heavily pretreated patients, some of these data may change. This looks at the overall survival, and it pretty much mirrors what you see with progression-free survival. And there won't be much discussion of this, but there's the question of what's life like after ibrutinib. And Dr. Woyak will be presenting something at ASCO, and I think this will be something that we'll be struggling with, for the Richter's transformation patients. I don't think it's a surprise when you progress with Richter's, you do poorly because most of those patients had multiple therapies. With CLL, I think there's hope, and again, this will be a discussion, but I think these patients have to be approached in a distinct way. So the conclusions of the pivotal trial, ibrutinib as a single agent promotes early and sometimes extended lymphocytosis that is clinically insignificant thus far with the data that's available. It induces durable responses. The 17P and the 11Q are a little less durable. And the toxicity profile for most patients has allowed extended treatment. Very few patients have gone off for toxicity that's directly attributable to drug. Most of the patients that have gone off went off with infections or something else, some other comorbid problem that required them to be off drug for more than 30 days. The data derived from the study looking at the 420 milligram cohort and also the food study provided the basis for the accelerated approval of the drug. And the long-term follow-up of this trial will be presented at ASCO by Dr. O'Brien in a poster. So there are additional studies that were prompted by this that are ongoing right now, and many of which are closed. This combination study with BR or FCR, mostly bendamustine rituximab, that's completed, and hopefully the paper is going to be coming back forward. The ibrutinib plus ofatumumab in CLL, relapsed CLL and SLL has been completed. It's clearly a higher response, and this will be presented at ASCO as well. The RESONATE-1, which Anders alluded to, was completed. There was a higher response, progression-free survival, and overall survival with ibrutinib reported in the press release. These data will be presented at ASCO this year, and I think everybody's excited. Although we probably know what the answer is going to be with this RESONATE-2, comparing ibrutinib to chlorambucil in untreated elderly CLL patients, because this will give an avenue for patients that we want to give this in the upfront setting. Finally, there's a large phase 2 study with 17P that's completed in the HELIOS study that's ongoing, looking at BR versus BR plus ibrutinib in relapsed CLL, and I believe that study is still accruing. So if you're sitting in the audience and you're thinking, I'd like to treat my patient in the upfront setting, I just want to make a push for these 2 studies that are going on in North America, in Canada. ECOG 1912, which is comparing FCR versus ibrutinib in non-17P patients. There's a 2-to-1 randomization to the kinase inhibitor And this study is open and accruing. Again, it doesn't allow 17p patients. And then the Alliance study that Dr. Woyak is heading, that's comparing ibrutinib rituximab to ibrutinib to bendamustine rituximab in patients over the age of 65. And this study has a crossover at progression, so everybody gets ibrutinib. And with that, I'll finish.